Hi, Prakash.
Hi,
With
hi.
you.
How are you? And what a great case by Andre. But we want to show something a little similar, but yet show some different technology here and how we can handle a similar type of lesion. So this is a patient who is presenting to us, and I'm going to introduce our team: Dr. Kapoor, Ray Lascano, Marichu Malloy, Reno Torres. Damien is somewhere here helping us, and of course Asma Khalik. So Asma, our fellow, is going to go and present this case.
So this is a 58-year-old gentleman with usual risk factors, hypertension, hyperlipidemia, and actually he is an ex-smoker, but he's also a current smoker. He keeps going off and on. So has a typical symptoms of lifestyle-limiting claudication, predominantly in his buttocks. They are bilaterally equal symptoms, and it's Rutherford class 3. And his exercise, these are actually his exercise ABIs. They are severely reduced on both sides. His resting ABIs were near normal. So this was sent to us by referring. And so the angiogram was done outside initially, and which showed severe, significant proximal aortoiliac disease, and it was sent to us for further
Thank you.
therapy.
So I think Jim McKenzie, if he's on the panel, he'll know this one. So Jim, this was done in one of our OBLs in New York, and the patient just had an exercise ABI, which showed he only walked about a minute and 5 seconds before he developed severe buttocks claudication. The doctor had taken him to the outpatient lab, did an aortogram, and realized that this is not something that you should do in the OBL, and referred him to us kind of in perfect time for our symposium, which worked out really well. So I want to show you the angiogram. So what we did was we initially got left access because the pictures weren't the best, and you can see here that the access point was at the common femoral. You can see there's some inclination of some eccentric calcification at the external iliac. Next. So then we did a runoff of the foot, and as Dr. Khalik said, there really wasn't much significant, SFA disease, and he has reasonable runoff all the way down to his foot. But at least by the angiogram that we have from before, it is 3-vessel, so we didn't take a lot of pictures here, but he does have 3-vessel to the foot. So then we went ahead and put a catheter up top, and then we did a digital subtraction angiography. And you can see with digital subtraction angiography, he's got a horrible bilateral bifurcation disease involving the distal aorta as well as the left and right common iliac artery ostium. He also has an eccentric plaque at the level of the right external iliac artery above the bifurcation, or just at the bifurcation of the internal and the external. And he also has another severe lesion, again, just above, I would say just at the junction. I don't have ipsilateral views here, but just at the junction of the internal-external bifurcation, but just above it. So I think it's still common iliac at that level. So this is kind of where we're at, and we wanted to talk to you guys about how you would approach this, how you would treat it, and so on and so forth.
BK, that's an interesting case, and it was left lower extremity claudicate. Did he claudicate on the right also, or just
bilateral? Yeah, but right is definitely greater than the left because he seems to have more significant disease on the right, especially at the common. But interestingly, Jim, is his hypogastrics are there, but
Right.
they're not really that robust, and so I think here at this stage, this is really a case for buttocks claudication, and how do you deal with this calcium? And do you or do you not have to use a covered stent and possibly sacrifice the hypogastrium? So what I'm going to do now is, I think we're going to take an injection from the left side, and I want to show you the actual bifurcation, so you can tell us whether you think we'll get away without touching the hypogastric. Inject. Okay, so I'm going to move my catheter up. Forgive me, I'm injecting from below. Vishal Kapoor didn't have his lunch today, but that's okay. So we'll do it now. Ready? Inject. So it's above the hypogastric, Jim. But if you go back plus to the aortogram, guys, so Dr. McKenzie can see while we treat this, plus, and Dr. Scheinert, and you can see here that the hypogastric is spared. So the question is, what I'm concerned about by looking at this, Dirk, and I don't know who else is on the panel, maybe Dr. Anbar is on the panel as well, is that distal aortic lesion at the base of the distal aorta I'm worried that I may disrupt that into the aorta if I go ahead and place a stent.
I think if you, the way I would approach it, 7 French sheath bilaterally, then gentle inflation, see how patient tolerates that. If patient tolerates it well, I would put Viabond VBX sticking out into the aorta, covering that spot over there. So that will be my approach. It looks like you have room distally not to cover the internal cartilage.
Have you done an LAO looking at the right hypogastric also?
We have, Jim, and it actually, we had a problem. We will show it to you in a second. It's above the right, above the bifurcation.
Okay, so both of your lesions are really common iliac lesions. And if he's got bilateral hip and buttocks claudication, I would probably fix both with kissing balloons. I like the VBX here because you've got some angulation there. And so I would pretty much do what Andre just taught us to do of going in and putting bilateral stents up and then inflating them under observation and do it gradually, knowing that you have a little bit of foreshortening. So I put a little bit further into the aorta with the VBX and then start with like a 7 and go up to an 8, and you can go to a 9, which I doubt you'll need, but I'd go 7, then probably 8.
So, I mean, we talked about that, myself and Dr. Kapoor, and I don't know what Dirk or Jim, Carlo, whoever's on the panel today would say, but what we were thinking is, in this situation, why not do a Shockwave device into the iliacs? We have, as you know, Jim, especially in the TAVR program here at Sinai, been using a lot of Shockwave to prep the vessel in these kind of very, very calcified iliacs. And it works very well in this particular area. So we've done the right already, and that's kind of why I was hesitating to show you what happened, which I'll hesitate a little further so you can see it in a second. Yeah. So we're going to do the left for you, and so we're going to go up with this balloon. So Dr. Kapoor, can you discuss this balloon for me?
Yeah. So Shockwave is pretty much like the lithoplasty where we do.
Put on
Yes.
regular.
So it essentially has the waves which are generated through the balloon. So the idea is to prep the balloon up as if it's coronary, and you inflate the balloon up to 2 atmospheres opposed to the walls, and then you start your the Shockwave treatment itself for 30 seconds. So the centermost balloon that's the most prominent where the waves come out and have the maximum effect. And as you go down to the edges, the effect of the waves itself is lesser. And you go for 30-second cycles. And every balloon lasts for like around 6 cycles. And so the idea is to crack open the balloon the calcium up in the media and the adventitial region. And once we have done to the 30-second cycle, we actually go up to 2 and 4 to crack the calcium before you actually come down and draw the balloon back. So the idea is to have a good apposition, break it up with the lithoplasty, go up to 6, and then you deflate it and come back.
So right now we're at 2, Jim, and you can see the tightest lesion is at the common. And now as it's going up, you're going to see it start to expand, as you see right now. And, it goes to low pressure at 2 and then go a little bit higher at 4. I've got my glow tape, which I know I'm in the aorta with that. See, they're starting to expand now even better. And right now we're at 25 seconds, and we're going to do another treatment there. See it expanded? Right there. So it expands quite nicely without having to go to high pressures. So we're going to go up to 4 atmospheres now, and then we're going to go ahead and do it one more time, and I'm going to pull it back. What happened? I guess I stopped it. There you go.
Now, would you pull it back or would you push it forward, since your mid emitter is all the other ones are paired, so 1, 2, and 4, and 5 are kind of sharing the energy, but that middle emitter is really getting all the energy. Would you push the middle emitter up to that focal lesion and try and crack it a little bit more vigorously?
Absolutely, Jim. What we generally do, you can get up to 6 cycles. So what we do is initially we keep it at this, treat twice at this level. Now we're going to go down, we're going to pull back and get that common iliac, external iliac sort of lesion. It's not quite it's still a distal common iliac. I'll properly classify it. It's a distal common iliac lesion. We're going to hit that a little bit more, come back. And then I'm going to do what you said, come back a little more to there you go. Now go up again. So again, we're going to go up to 2 atmospheres. And while Dr. Kalik does this, I want to show you what we did on the other side. Okay, there you go. That's it. There's your lesion. Go. Start.
I'm going.
It's already cracking. 4, 6. Now let's show them the other side. Go scene plus all the way to the.
Oh,
There we go. There we go. So you can show that
oh,
lesion.
that one, okay.
So this is the right, which we did offline just to save time. I know we're running behind, so
This was not, yeah.
one more.
One more.
And you can see here, one more. Show the lesion first, guys. Keep going. One more. One more. Okay. Okay, so now the balloon will go up. Next.
Go forward.
Okay, this is us getting ready to shockwave. Next.
This,
Oh, there was one before.
Next one, please.
yeah,
Yes.
next. Yeah.
Next one, please.
Next.
I guess I didn't see any of that, or I did?
I think you did. Let me
There you
try
go.
this.
So all this was a shockwave balloon. I thought I sent it. Go scene minus. I want to show. 1, 2, 3.
Yeah, I'm trying to. That's why you
One
just
more.
did it right.
One more. There you go. One more. One more. And you'll see it. Now you'll just watch it expand.
There.
So there it is, guys. So there's the tightest lesion up top, and then at the common iliac, and you can see as the shockwave goes, it slowly pops at just 4 atmospheres with the shockwave balloon, and then show the final result now. Plus, plus.
No, this is.
One more.
Yeah, right there. This is the one.
And this is the final. So you can see here the final result really shows that we've expanded the lesion well, both in the common and in the external junction. And now I'm going to do what you want me to do, Jen, which is show you the iliac shot, which will show you whether we're at the level of the bifurcation or not. Ready, Cine guys on this side?
On this side, right? Yeah, one side.
Inject, please.
Yeah.
Hold on. Let me do this.
The size of the urinary bladder gives away that you were
Not
working
confusing.
for
Yeah,
quite some time.
Actually, we had done an IVUS, and we actually weren't working that long on VAR because I was in the other case in room 4. So I think Vishal was just taking diagnostics. We took a lot of runoffs down. So I want to show you the IVUS. Show me the intravascular ultrasound. Show me the video, please. On the right first. And you can see this is the right IVUS as we run up.
Let me pull it back.
And literally, it was very, very simple. Look how tight that was in that area. And then now we're going to do a post-IVUS after we come down. So look at that. Look how tight that was. Very complex lesion. And now show me the left, please. And you can see in the left, there you go. Very tight at the distal common. And then coming towards the proximal, again, it's going to narrow down again at that stage.
Yeah. That's one thing I found very impressive, and I think we were
Down.
one of the first to use this for TVAR, and then
Show me
we
above.
got a lot more acceptance with it. But I was just doing a case on Friday,
go
and
up.
I had to put a 24 French dry
Go up
seal
here.
up, and it wouldn't go. And,
Right.
and we tried dilatation and everything else. Then I came in with a Shockwave, just a 7mm balloon, which is smaller than what you need.
go.
But just doing that, then suddenly I was able to get that
Coronary, please.
24 French dry seal up
I'll
without
do easy.
any trouble at all. So it is pretty impressive of what you're able to
It
do
is.
when you're changing really the calcific nature of these plaques.
And Jim, what I did here in Anbar is I put up the shockwave balloon into the aorta. It's obviously grossly undersized there, so I'm not worried about causing any damage. And I'm just expanding it right in the middle zone that Dr. McKenzie was saying for another 30 seconds. And then when we're done here, we're going to have to switch out and then decide what we want to do. Well, I mean, in this stage, it actually almost makes me feel like we don't need to do a covered stent. Down. And I'm curious what you guys would do. If you could show the pressures, you can see the pressures are now back to normal. Show the regular, the waveform for us. Walk it back, please.
Yeah.
PK, you may be able to educate me on that one then, because I generally use the covered stents to try and inhibit further intimal hyperplasia in reaction to the
Ready?
angioplasty. So I'm not sure if I would change my algorithm
Yes,
by using Shockwave. I'm not worried about embolization because the Shockwave really affects more the medial calcification. So what would be your reason not to use a covered stent with using Shockwave?
Well, Jim, I mean, I got to tell you, I don't know what Anvar and Dirk would do here, but for me, the Bravissimo, it's a registry, but a well-done registry, showed that, the lesions, we're going to have to put an aortogram up, the lesions that were done with even TASTI with the balloon expandable stents did quite well. To me, at this stage, I think this is calcific disease, and I think what we could do is save money, obviously get away with putting a bare metal stent since we've expanded the lesion. We know we have IVUS to size the vessel so we can go 1-to-1, so limit our rupture risk. And we've expanded the lesion, so I think our pressures will be lower. The other thing is, if for whatever reason I'm a dope and I pull it across the common internal iliac, then I think that I don't run the risk of having the internal iliac closed by a covered stent. So that's one of the logic I would think of. Second, there's no size mismatch here, where I don't have to worry about sizing it properly. I can obviously put a 1-to-1 size and not worry about expanding one side less than the other or having a post-stenotic dilatation wire out. Post-stenotic dilatation. So that's kind of my logic there, Jim. I'm not saying I'm going to do it. I'm just kind of playing devil's advocate and talking about different ways to approach this.
It definitely does make sense because even if you haven't done Shockwave, there is still a risk if this is supercalcified lesion, then you won't be able to dilate it. You can use balloons and then run into situation that balloon does not expand. And then you ask yourself, should I risk putting stent there, or then I won't be able to expand the stent, and the patient starts having pain, and that leads to all kind of problems. I think your approach was brilliant, and now you know that you can expand whatever stent you choose. I think putting wire-bound stent VBX probably is the safest approach, but right now at this time you can probably easily put bare metal balloon expandable stents and you will be totally fine.
So you know what, I have you guys, and I'm lucky to have you guys on the panel, and I want to know what you guys would do. Because I think here I am kind of at both, because I do agree with you, Anvar. There's always a chance, no matter what you think and how well you've expanded it, that you could. But the question is, 2 VBXs have been expensive, and Giancarlo and Dirk have often brought up the cost, which I think is very relevant, of the procedures that we do. So I think that, the COBEST trial, I agree, does show benefit, but we do have registry with Bravissimo that shows that we may not need to do that in these cases. So I wanted you guys to take a vote, and then I'll see what we can do. What do you think? Let's take a vote. What do you think?
PK, just plain devil's advocate, would you consider not stenting in the situation where you have substantial luminal gain with just simply the Shockwave?
That's a great question. Let's go to the angiogram. Go scene minus. So on the left, let me see. So on the left, it looks like we have a nice expansion without much dissection. On the right, that vessel is in tatters. Sure, go to my injection of the right from the bottom. So to answer your question, I think on the left, I would agree with you. Keep going minus to the post this picture.
Yeah.
Yep. You can see here in this picture that it is quite much in tatters. No, you got to go to the right one. So I think that leaving the left with the PTA alone may not be a bad idea, but it's not usually part of my practice. I do stent these, and I'm curious to see what the panel would do.
Yeah. If this were my case in my hands, I'd feel like I could very accurately land a balloon expandable stent, covered stent. In your hands, I'm not as sure. So.
I totally agree, Jim.
No, PK. All kidding aside, no. PK and I go at each other all the time here. But no, I think a covered stent's still the way to go.
Yeah.
I think you can be penny wise and pound foolish here to give you the best long-term result with this. Because you've done a nice job. You don't have to put a lot of pressure in there. Just go in very accurately, deploy the distal aspect of your stent, and I think you'll be golden.
30 minutes is fine. So
the risk of restenosis in iliac stents is relatively low compared to let's say SFA. So I would definitely go ahead and stent it. I think it's safe, and you have nothing to lose.
Got it. And I think
in this situation, I think I hear you. Covered stent probably has less chance of restenosis for sure. But I think you can get away with non-covered stent as well.
So now we have a couple of covered stents now, which we're blessed to have, thank God. One is the VBX and one is the Livestream. What are your thoughts? I don't know whether any of you are strong-minded about any one stent versus the other. Should I put one in one and one in the other to see how they work? No. Okay.
Randomized trial.
I would put similar stents in there. Because again, with the interaction and then the compliance of them, both are balloon expandable. I think both would work very well here. quite candidly, I'll play a member of the program committee here. Since we just saw a live stream, I would go in and put a VBX in so our audience can see the two different stents and how they deploy and everything else.
Yeah, so I
too
agree with
long,
you
right?
there, Jim,
Perfect.
and you are a member of the program committee. So I totally agree with you for multiple points, but we need to elucidate the advantages of the VBX and the live stream. Live stream goes through a 6 French up to a 7.0 or an 8.0?
8.0.
8.0 goes through a 6 French. The VBX, you're able to expand it, especially the VBX XL, which is an 8 French sheath compatible. You're able to expand that up to a 16, right, Mike? 16? You're able to go up to a 16. So we tend to use VBX when there's mismatches.
Yes,
When we have mismatches, we'll use a VBX and then balloon the dilated segment up to whatever luminal diameter we need, and leave the proximal segment across the stenosis excuse me, at the nominal size. That's the advantage of the VBX. It's also very deliverable. The 7.0s also can go up to 12, I believe. 11. 7.0s can go up to 11. So this particular stent is a 7.059 that I'm using in a 7 French sheath going up to 11. I'm going to do a DSA whenever Asma is ready. Oops, sorry, I hit the wrong button there. And then we're going to make sure we hit the ostium. Go ahead, inject. I don't think we need to do kissing here, Jim. So we're going to kind of hit it without one at a time if you're okay with that.
I prefer to put them, like align them next to each other, and I don't know. That's my approach usually.
I like this where you're really concentrating where that hypogastric is.
Right.
You can deploy it. You're in good position there. As long as you keep your wire there on both sides, I don't think you have to do kissing. And I would just go up and, as you're kind of describing, inflate. Just make sure you nail it just where you want distally, and then come back and do the other side with equal intent.
Yeah, I'm just going to pull it back slightly. I think I agree with Anvar, maybe a little overkill here. And I'm just going to go ahead and hit it. And I think for the audience, this is kind of the thought process, we all share. Are you guys okay there? You would come back more.
I'm good there.
Could you run it one more time?
Yes, it's coming right now.
I think you come back a hair.
Well, he did come back. That's the one.
I see.
You haven't reshot. That's before you pulled back a little bit.
Yeah, but I want you to see the location of our hypo. That's kind of the balance, right?
Right, and that's why I wouldn't come back any further.
I think
Yeah,
you're good here.
Yep.
Let's take another look here, guys. I'm just going to, we got a normal creatinine, so we'll take a little advantage.
Your bladder's catching up to your hypogastric now.
I think that's a good
That's
position.
a good position. All right, we're going up here.
Time for a Foley
Nominal?
catheter.
Go up. Again, I tell you, Anwar, I don't know, who's helping you at NYU. Dr. Kapoor loves contrast.
He has an ongoing relationship with the nephrologist too, though.
So you can see here, we're going up. That was only at
6,
3 atmospheres.
4,
What's
yeah.
nominal, guys?
12,
12. He's going to have a little bit of pain, which we know he's going to have.
4, 6,
6, 8,
going to 8,
10, 12.
going to
12.
12.
Okay, that's our at nominal. Okay,
Down.
and then down. So again, it's important for the audience. We have a pressure manifold. We're watching pressures as the balloon comes down. There's always a chance, even with a covered stent, it always gives you a false sense of security that you can get away with anything you want. And here, clearly the pressures are very good. And we're going to walk this out slowly. I'm just going to fix my sheath. And then, there you go. And then we're going to take one picture, make sure we like this, and then put up another stent. I think the key here, Jim, and I think for Anwar, I think you would totally agree with me, is that hypogastric. I have a question for you. Say you have the same patient with occluded hypogastrics. Would you still fix the common iliacs?
Nice.
With occluded hypogastric, I mean, yeah, because he's still claudicating, and your profunda is going to supply blood flow to the pelvis as well as your IMA.
What is he?
So I definitely would open him back up and count on retrograde flow from the profunda as well as antegrade from the IMA.
So my question to you is, would he have as profound a relief of symptoms as he's going to have now?
Your guess is as good as ours.
I'll tell you why, because, we run into those, and then, those are very difficult to treat. And then you often wonder, when they come back to you and say, well, I thought I'd be feeling better, and I'm still not feeling that good. And then you start to wonder, well, did I do a procedure that was really not necessary?
Yeah.
So, that's why I asked Jim and you, Anwar.
Well, I think if you're doing it for erectile dysfunction, then I'd say there's no chance. If you're doing it for buttocks claudication, I would say I would do it because obviously the IMAs are not enough because he's there complaining of
Another
it
one?
still. So I definitely would go ahead and treat him to give him the best flow and hope that through the profunda. Now, if he's got a profunda stenosis also and an SFA occlusion, I'd probably do a hybrid procedure where I'd do a common femoral and profunda endarterectomy and patch angioplasty,
59.
then retrograde treat the common iliacs. And that, I think, would probably get rid of his buttocks claudication, too.
Thank you.
All right, so now we're going to put another 58, 7058.
59.
59, forgive me. So
Now-
now, as far as antiplatelet therapy, anything different that you guys would do in this situation?
Data-driven or anecdotal?
Both. What does the data say, and what is that? What does Jim McKinsey and the panel recommend?
Data, I don't know of any good data saying that one thing is going to make a difference over the other. I tend, for common iliacs, not to do more than single antiplatelet therapy. If I was to go more distal to that, then I tend to go ahead and dual antiplatelet for 30
Coronary
days.
guys? Got it. Anbar?
I usually keep them on dual antiplatelet therapy for 1 month. And it depends then on comorbidities. The patient also has coronary disease and let's say some other peripheral diseases, vascular path, then I take aspirin off and keep them on Plavix.
Yeah, if it's isolated iliac disease, I just do
Yes, sir.
aspirin.
Oh, you do aspirin. Wow, that's fantastic. So isolated, even with covered stents, you just go ahead and do aspirin, or do you look at the runoff before you do it?
No, I think if it's isolated common iliac disease and you have covered stents, I mean, I would just do aspirin. We do aorta bifemoral bypasses all the time. We don't keep them on anything but aspirin, and I think that
Actually very good.
there's such high flow and they're large caliber. I mean, you're doing 8 mm VBXs, large caliber, high flow. I
see
think
the
aspirin's
hypogastric?
sufficient.
Yeah, so we're a little
Don't see
concerned
it.
about the hypogastric here. I don't know whether you guys saw that. So we're going to go and take a good look here. Approximately, I think we're good.
Well, I'll cheat. Generally I see the ureter will cross right over the hypogastric,
Okay,
and
great.
that's
you're
a good
good.
marker.
Yeah.
I think you're fine.
Yep, I agree.
see it.
We're gonna. I know you saw approximately, right, guys? Go C minus.
Yep.
I just want to make sure that we're all on board because I think it's a nice case. Yep, we're good. Let's go up.
Okay, going up. Going up.
You can even cheat up a
2.
tiny bit if you'd like. I think it's going to
And
shorten.
I like it right
wait,
where
the-
it is. Just
No,
because
They
he's
said
the other
I'm
stent,
at
he's right at
4.
the same
Ready?
level.
Ready? Yep,
Yeah.
go up.
Yeah, I agree.
Yep, I like it too. Right there.
There you go.
Nice.
Yeah, thanks.
The only thing I do have, you have to worry about, so you can say these can go up to
8.
11, but you will have some foreshortening also.
Yeah.
And when you use the 8L going up to 16, you'll have significant foreshortening. So you have to
8
kind
and
of
10.
plan for that as you do
12.
it too.
12.
Okay, down. That's good.
Down.
Okay, so we did go up again one more time. So we deployed both at nominal, and we know IVUS sizing, it was about a 7-8 iliac, common iliac,
Went up again.
with some poststenotic dilatation which went up to a 9 at the level of the distal to the stenosis in the left. So we're now going to go ahead and take a shot. As far as surveillance for this, gang, what do you guys normally do? Do you do ultrasounds? Do you symptom-wise? How do you treat these?
Physical exams to start with. Do you have good femoral pulses?
Are
Then
we doing
take a
this?
history from them. Are they walking without pain and everything else? If any questions, I'll do a duplex.
Okay. Wow.
Yeah, I think we're
very
done.
Nice.
Excellent.
That looks
Yeah.
great.
Yeah, I think it was a good demonstration. I think what we'll do is now it was very important. We'll do completion runoffs to the foot, make sure we haven't embolized, even though Jim and I and everyone here feels that likely not, especially with Shockwave. But iliacs can always embolize. And then what we'll do is we'll go ahead and close the groins with perclose. We have good common femoral access points here. And I think at this stage we're done. I think it was a good demonstration of a different way of tackling a calcified iliac. And honestly, I think covered stent is plus minus here. If you wanted to use a balloon expandable nitinol stent, I think it would have been pretty reasonable. Or even left side alone with the PTA as was suggested.
I think the Shockwave is dramatically changing how I look at these lesions now. It works exceptionally well. It's low pressure. You're low risk of rupture. And you can just kind of slowly titrate it up. So I think it's going to change it. And I think Dr. Tadra's question and the other question of, do you need to use a covered stent now, or do you even need a stent at all? these are things we have to kind of look into more. I think we need to relook things, and cases like this help stir the enthusiasm and say, what should we be doing and how can we make sure we do it safely and at a lower cost?
Well, it's so funny. I didn't recognize Rami's voice. I didn't know that was Rami, but I got to tell you, Rami is the reason we're doing this, because Rami's been doing this for the TAVR program for quite some time, and he, he's kind enough to show us his techniques, and this is one of the things where we collaborate so well together. So, Rami, this is all on you. Thank you again. And thanks, guys. It was a great case. Thank you.
Excellent case.